Hi everyone, and welcome to another Teach to London episode. My name's Pav. I'm an FY3 doctor working in O&G and emergency on the Central Coast in Australia, and this time we're going to be talking about gestational trophoblastic disease. Now, very quickly touching on GTN, this is what happens when some of the molar pregnancy tissue persists in the uterus and is diagnosed by HCG levels not returning to normal. GTN can also be diagnosed after a miscarriage or live birth, but this is much rarer, happening once every 50,000 babies born. Development of persistent or irregular bleeding after a pregnancy may be a sign of GTN. Other symptoms include abdominal pain, distension of the abdomen, but women should have a pregnancy test to exclude this and to have an ultrasound scan as well. Now, invasive moles describe the condition where a complete or less frequently a partial mole invades the myometrium. It's clinically identified by a persistently elevated or in fact rising level of HCG following uterine evacuation and also an abnormal uterine ultrasound scan. A pathological confirmation is rarely required, but on the cases where histological information is available, the invasive mole can be distinguished from gestational choriocarcinomas by the presence of chorionic villi. Gestational choriocarcinomas can occur after any pregnancy event. A quarter to one half occur following a complete molar pregnancy, a quarter within 12 months of a non-molar abortion, and another quarter to a half occur after a term pregnancy. Symptoms could be early, such as PV bleeding or pelvic mass, with late symptoms such as distant metastases from liver, lung and brain mets as well. HCG is always elevated, but it may be a difficult pathological diagnosis because of the frequent hemorrhage and necrosis that accompany it. It's a particularly nasty disease because it's a tumour that crosses the placenta, so the newborn of a mother newly diagnosed with choriocarcinoma has to be investigated to exclude disease, and that's done by doing a urinary beta-HCG test on the newborn. Final two things are PSTT and ETT. Now, PSTT is a very rare cancer that frequently presents as a slow-growing tumour a number of years after a molar pregnancy, non-molar abortion or term pregnancy. It usually presents with predominantly gynae symptoms, as metastases are much later and rarer than in choriocarcinomas, but very rarely patients can also present with hyperprolactinemia or nephrotic syndrome. Usually the HCG levels are also low, unlike we've talked about previously, and they're low relative to the volume of the disease. So you'll usually have low levels with quite a high volume of the disease. Treatment as well is usually a hysterectomy, as it's less sensitive to chemotherapy than the other cancers. And very finally, the epithelioid trophoblastic tumours are distinct but very rare forms of GTN. It's a disease of the intermediate trophoblastic cells, and diagnosis is often really difficult to make, so differentials usually include choriocarcinomas, PSTT and SCC of the cervix. The disease itself is characterized by a really long interval from the previous pregnancy and more commonly follows a term pregnancy than a molar or a non-molar abortion. HCG levels are once again generally lower than that of a molar pregnancy, and the behavior of ETT is less aggressive than choriocarcinomas but has a much higher potential for metastatic disease. Once again, the primary treatment for these tumours is actually surgery rather than chemotherapy because it's in fact resistant to it. And the factors listed here are usually seen with a poorer prognosis. Now, for the majority of women with GTN, chemotherapy is the treatment of choice, and women are assessed before chemotherapy begins using the FIGO 2000 scoring system. And women with scores of 6 or less are low risk and are treated with a single IM methotrexate injection alternating with folinic acid. whereas women with a score of 7 or greater are high risk and are treated with intravenous multi-agent chemotherapy. It's got a really high cure rate, and treatment is continued in all cases until the HCG level has returned to normal, and then for a further 6 consecutive weeks. For women with a score of 6 or less, the cure rate is almost 100%, and for women with a score of 7 or more, it's still 95%. For the women that do receive chemotherapy, they're likely to have an earlier menopause than women who don't, and usually it's 1 year earlier if it's monotherapy or 3 years earlier if it's a combination therapy. Women who also undergo chemotherapy should be advised not to conceive for 1 year after their treatment has finished. And finally, those ones who are high risk and have required multi-agent chemotherapy, which includes etoposide, they should be advised that they may actually be at an increased risk of developing secondary cancers